All right then, we'll start very shortly. I'm just going to wait for a couple of people to join the room. All right, so just going to want to extend a huge welcome to everybody out there for this week's Winter-Spring webinar series on the topic of the biology of lymphoma. A warm welcome to all of our LBC community of patients, families and supporters out there who have tuned in. I hope you have a lovely cup of tea or maybe some coffee or your lunch close by and that you're ready to get comfortable for today's session. My name is Natasha and I'm one of the Support Services Coordinators for Leukaemia and Blood Cancer New Zealand. I'd like to extend a huge welcome and a big thank you to Dr Samar Issa, who is here with us today and who I will introduce shortly. Firstly, I'd just like to let everyone out there know how today's session will run. The wonderful Samar will share with us her presentation and you're all welcome to submit questions as we go, and you can just pop those in the Q&A section at the bottom of your screen. So these will be answered at the end of the talk. We will be limited on how much time we'll have for those questions. So please note that any questions that aren't answered today will either be answered on our YouTube video that we'll post in the coming days, or in the Lymphoma Facebook group, or some of the talks to come. It's also worth noting that this talk will be one of a series of talks about lymphoma. So specific questions about subtypes of lymphoma might be answered in the relevant talk. So just a bit of an introduction to Dr. Samar. She is a consultant haematologist and the clinical head of the Lymphoma Service at Middlemore Hospital. Dr. Issa graduated from the School of Medicine at Baghdad University. She trained in Auckland where she gained the fellowship of the Royal Australasian College of Physicians and the Royal College of Pathologists of Australasia in 2007. She undertook a fellowship in translational research at the University of California, San Francisco. Her research focused on central nervous system lymphoma. Dr. Issa is an active member of a number of scientific groups, is the founding chair of the Lymphoma Network of New Zealand, and the founding clinical director of the Middlemore Tissue Bank. She has multiple research publications and is the primary investigator on several local and international lymphoma clinical trials. Also, Dr. Issa has authored a few book chapters in the field of lymphoma. So I will now hand over the time to Samar for her presentation. Thank you so much, Samar. I'll hand over to you.
Thank you so much, Natasha, for the introduction. And I will share my screen now and start the talk. So our talk today is the first in a series of talks about lymphomas. So I welcome you all to this webinar, and hopefully you will find it useful as an introduction to the subsequent talks that will specifically detail the different subtypes of lymphomas in subsequent weeks. This talk also is timely because next week on Tuesday, the 15th of September, it's International Lymphoma Awareness Day. So enjoy this talk. Please don't hesitate to post your questions to the website, and I will try to answer them after I finish the talk. So I'll start with a simple slide on a concept of lymphocyte. What is a lymphocyte? The lymphocyte is the smallest white blood cell. It circulates inside our blood vessels and it's part of the immune system. The lymphocyte is composed mainly of a big, round, condensed nucleus at the center of the cell, and that is surrounded by a cell membrane and a small bit of cytoplasm that contains all the vital organelles that keep the cell healthy and functional. They comprise around 20 to 40% of all of our white blood cells. And these cells, little cells, the lymphocytes, are born inside our bones. It's a place that's called the bone marrow. The bone marrow is the birthplace of all of our blood cells, including the red blood cells, white blood cells, as well as the platelets. And this is a schema of our skeletal system where the bone marrow exists. And I just put this little hip image here because the ileum is the site where we take bone marrow biopsy to diagnose and stage few of the known lymphomas. What we take is a small bit. We look under the microscope to look at all the cells and make the diagnosis. There are a few types of lymphocytes. So according to the lymphoid cells, after they are born inside the bone marrow, according to where they go, according to their cell surface markers, and according to their function, they are divided into three categories: T lymphocytes, B lymphocytes, and natural killer cells. They function differently despite they are born and divided from the cell that is called the stem cells, or a common lymphoid progenitor cell. That cell can differentiate and form our T cells. There are two types of T cells: T helpers, which help kill viruses in the infected cells, and the T lymphocytes that are called the cytotoxic T lymphocytes, which act as the maestro of the immune system. It coordinates B cells and macrophages to help attack the bacteria and the viruses and protect us from infections. And of course, the other big subtype of cells, of lymphoid cells, are the B cells, which produce antibodies, and they are also known when they mature as plasma cells. The last subtype of the lymphoid cell is called natural killer cells. These are part of the innate immune system, which creates rapid response against viruses and infected cells. This is rapid killing and immediate action. There are only few of these cells in our bloodstream. As I said, the T cells are the maestro and the coordinator of the immune attack. They activate the B cells, which in turn produce antibodies. They help activate and recruit macrophages, which act to clean up the invaders and the dead tissue after the immune response is complete, and they also have direct activity against all the invaders and the foreign particles. I've talked about antigens. So what is an antigen? An antigen is a substance that is capable of stimulating our immune system. It specifically activates the lymphocytes. In general, there are two types of antigens. The first one is a foreign antigen, which includes bacteria, viruses, even insect venoms, foreign proteins, any other foreign material that enters into our body. The other type of antigen is called self-antigen. These include our own tissue and also, unfortunately, some of our cells that become cancer cells. So these are autoantigens. Our immune system responds to both types of antigens and is our defense system against them. Here you see is a B lymphoid cell, a small cell with big, round, beautiful nucleus. These B cells start releasing antibodies when they get the signal from the T cells. Those little dots are the antibodies. They start surrounding all the antigens, which include, as I said, foreign material, viruses, bacteria, etc. And these antigens, they are foreign to our body, so they need to be eliminated. There are three subpopulations of our cells: the B cells, the T cells, and the NK cells, which act differently, as we said. So now in turn, we'll be talking about antibodies. So what is an antibody? It's also called immunoglobulin, which is a protective protein that's produced by our B lymphocytes in response to the presence of an antigen. And an antibodies are recognized. Here they are. They can recognize the foreign antigens and bind to them and eliminate them from our from our blood via the activation of the immune system. What happens here is the antibodies form aggregates. They cross-link to each others, and they form aggregates that surrounds the foreign molecules. They surround the viruses, the bacteria, any other foreign molecules. Form a cluster. These clusters get recognized by the macrophages, and they get cleared from our body, and our immune system is very efficient in doing so. So how do we identify the different types of lymphocytes? There are B lymphocytes, there are T lymphocytes, there are NK cells. We can look under the microscope to see these types of cells, but they mostly look similar. So we have a better way of specifically identifying all these types of cells by looking at their surface markers. The surface markers refer to membrane proteins that are embedded in the lipid bilayer structure of the cell membrane, which include receptors and other molecules on the surface of the lymphocytes. So each type of lymphocyte has different surface markers, and that's how we are able to determine what type of lymphocytes we're looking at. these surface markers also help the cells, the lymphoid cells, interact and talk to each other. So they are extremely important. For example, on the surface of a B cell, there are specific markers or receptors like the CD20 or the CD19. These are really important because nowadays we've developed specific treatment that can target these receptors and eliminate the abnormal lymphocytes, i.e. the lymphoma cells from the body. So that's why we can look at these surface markers and be sure what we are dealing with. The surface markers are generally classified into three major categories: surface immunoglobulins, antigens, or membrane receptors. The latter is the one that we mostly look at. So you might have heard about a test that calls cell marker studies. What we look at during these studies is the cluster of differentiation molecules that exist on the surface of these lymphocytes. For example, the T cells are commonly exhibiting or showing CD2 and CD3 molecules, while the B cells, they have CD19 and CD20 antigens on their surface. Natural killer cell, on the other hand, they have CD16 and CD56. By doing these surface marker studies, we can be sure the subtype of lymphocyte we're looking at, and in turn the type of lymphoma we are dealing with. So how do these lymphocytes develop? As I said earlier in a previous slide, all of our blood cells, they arise from one mother cell. It's called a stem cell. That stem cell start growing inside the bone marrow and start differentiating into a common mother lymphoid cell, it's called a lymphoid progenitor, and a common mother myeloid cell, which is the mother of all the myeloid cells. The myeloid cells include the red blood cells, the platelets, all of the other white cells, basophils, eosinophils, and neutrophils, and monocytes. They all come from one mother cell, is called myeloid progenitor. What we're interested in today is the lymphoid progenitor cell that gives rise to our B lymphocytes, our T lymphocytes, and our natural killer cell. So how does that cell know, the pluripotent cell, know how to differentiate into all of these subtypes of the blood cells? That happens because of certain signals that this cell receives from our body through products that are called cytokines or growth factors. So each certain type of a growth factor make that cell differentiate into a different blood cell according to our body's need. So it is a very good system, and it works really, really well to provide our bodies with all the types of important blood cells that we need. For the lymphocytes, after a lymphocyte is differentiated from a stem cell in the bone marrow, as I've shown in the previous slide, it either becomes a B cell or a T cell. The T cell leaves the bone marrow immediately and heads to the thymus. The thymus is the small gland that is located at the anterior part of the top of our chest, right between the apex of the tip of the lung, while the B lymphocyte stays in the bone marrow and starts maturing inside the bone marrow. The mature B lymphocytes and the mature T lymphocytes afterwards, they both leave the bone marrow and head to the lymph nodes and spleen to get educated. These two types of lymphocyte, despite they are mature, but they are naive. They cannot fight infections. They cannot produce antibodies, for example, the B cell. But once they head to the lymph node and the spleen, they get the education that they need to make them part of our active immune system. And that is what the lymphatic system is made of. The lymphatic vessels that carry all the lymphoid cells around the body, and the lymph nodes, which are the schools that educate these mature but naive lymphocytes. They arrive to the lymph node or the spleen. They become educated through different processes and procedures by introducing them to different antigens, make them mature cells that secrete antibodies, and then they leave the lymph nodes and police our body and fight against the antigens or infections. And it is really important that the lymphatic system is healthy and the cells are ready, because it is our body's main fight against infections. There are three types of lymphoid tissue. Primary lymphoid tissues, which is the thymus, as I said, and the bone marrow, where the cells mature. The secondary lymphoid tissue, which is the lymph nodes and the spleen, where the cells, that's the lymphoid cells, get educated. And there is a tertiary lymphoid tissue, a little bit of lymphatic in our skin, and the mucosal membranes that surround our gastrointestinal tract and our respiratory tract. So with this introduction, I think that we know through the maturation of the lymphoid cell in different parts of our body, it is a process that requires a specific and very accurate interaction of our lymphoid cells with the environment in the bone marrow and within the lymphoid cells. So the types of different lymphomas that we have reflects that developmental stages of lymphocyte. So each type of lymphoma can be viewed as a lymphocyte that transforms into a malignant lymphoid cell at a certain stage of its development. 85% of these lymphomas are B cell in origin, the rest are T cells, and very small minorities are NK cell in origin. This is to simplify what I've just said. You have your B lymphoid cell, it is inside the bone marrow, it's getting mature, leaves the bone marrow, heads to the lymph node, here the lymphoid tissue or the spleen, and starts getting educated. It's still naive, but it needs to become educated to starts secreting antibodies as a plasma cell. So if the transformation of that beautiful and important lymphoid cell happens in the bone marrow, that's what we call leukemias. Leukemias arise in the bone marrows, while lymphomas mostly arise in the lymph nodes. And this developmental process reflects the different type of lymphomas that we have. So if the transformation of the lymphoid cell happens in the mantle zone of the lymph node, it's called a mantle cell lymphoma. If it happens in the germinal center of the lymph node, which I showed earlier, it just becomes a diffuse large B-cell lymphoma, follicular lymphoma, Burkitt lymphomas, or Hodgkin lymphoma. If the transformation from a normal lymphoid cell to a malignant lymphoid cell happens at the margin of the lymph node, it's a marginal zone lymphoma. And of course, the end product, the plasma cell, if the plasma cells become a malignant or a cancer cells, it is a disease that we call multiple myeloma. And hence we have so many different types of lymphomas. There are 67 subtypes of mature lymphoid neoplasm reflected by these different transformations at the different stages of the lymphoid cell development. And the concept of cancer is not recent. It was first described in 1858 by this man, Rodolphe Virchow, who described the malignant process as omnicellularly ecellularly, which means that one cell multiplies and spreads in the body. It resembles the mother cell. And all cancer cells come from one single cell. So how does that single cell happen? What happens to our normal, beautiful lymphoid cells, for example, the purpose of this talk, for it to transform to a cancer cell? It's a complicated process that involves multiple abnormalities or mutations, we call them, in important genes within that cell for it to transform from a normal cell to a cancer cell. And now we believe that cancer doesn't happen haphazardly. It doesn't happen to every person, because you need multiple hits, multiple mutations within a cell for that cell first to survive. It needs to acquire genetic mutation for it to become immortal. So what happened first? It switches off the tumor suppressor genes, which are the genes responsible for the cells to die or self-destruct. We call the process apoptosis. Once the cell stops dying and stays dormant within our tissue, for example, the lymph nodes, it starts acquiring more genetic mutations to enable it to start multiplying. We call that acquiring an oncogene, or a gene that enable it to proliferate or multiply, and that's when cancer happens or a tumor happens. The cell doesn't die and continues to multiply. You would ask me that, Samar, but you just described our immune system. It's a great and amazing system that works so efficiently in detecting all the antigens, including the cancer cells, the abnormal cells in our body. So how come these cells are not eliminated by our foolproof immune system, those powerful T cells, the maestros, those powerful NK cells, and the other immune cells in our body. The reason is that those cancer cells, they are clever. They gradually start acquiring more and more mutations within the genes that make them evade our immune system, escape the immune system of our T cells. They also start secreting or exhibiting some markers or antigens specifically designed to numb these T cells. So our immune system stops identifying them, they escape the policing of the T cells, and they start multiplying and cause a problem, i.e. lymphoma. So what's the cause of the lymphoma? The cause of the genetic mutations that cause lymphomas are well known. We know the genes implicated in forming lymphoma in the different lymphomas in our body, but we don't know what causes these genes to mutate. Possible factors include immune suppression, that our immune system is low, so the cells start proliferating, increasing in size and number, and multiply and evade the immune system. Chronic inflammation and also suppresses our immune system. Sometimes DNA repair defects, these are mostly congenitals in young kids. Viral and bacterial infections are well known to contribute to the genetic mutations that cause lymphoma, including, for example, H. pylori infection in the stomach linked to mold lymphoma, EBV infections to Hodgkin lymphoma, HIV infection to different types of B-cell lymphomas like Burkitt lymphomas, and so forth. Toxins, heavy metals, toxic materials exposure can also lead to some mutations that can lead to development, for example, to multiple myelomas, and of course, radiation exposure. Non-Hodgkin lymphoma is more common than Hodgkin disease. And the incidence of lymphoma is rising, including here in New Zealand. In 2002, there were 637 cases diagnosed. But in 2017, there were 1,032 new cases diagnosed. 113 Hodgkin lymphoma, new diagnosis, and 910 non-Hodgkin lymphoma. So the incidence is rising, unfortunately. 85% of these lymphomas are non-Hodgkin lymphoma, which is the 6th major cause of cancer death every year. And the most common types of non-Hodgkin lymphoma is the aggressive, diffuse, large B-cell lymphoma, which comprise 31% of all of our lymphoma diagnoses. The rest are indolent and T-cell lymphomas. The most common subtype of indolent lymphoma is follicular lymphoma, 35% of all the lymphomas. It's slightly more common in men than women, and it's a disease of older age. So you see here, we have the incidence rise with age. The median age of diagnosis is 60. And in the entire of the world, the incidence is rising with time. Unfortunately, despite all of the new treatments that we have and the targeted treatment, the mortality rate is still rising. 2% rise per year, and it's the third highest rise, exceeded only by lung cancer in women and malignant melanoma. Hodgkin lymphoma is fortunately less common. It's highly treatable and curable, especially in younger age. And the hallmark cell for Hodgkin lymphoma is called Reed-Sternberg cell, which was first described in early 20th century. Unlike Hodgkin lymphoma, Hodgkin lymphoma has a bimodal distribution. So it's common in teenagers and young adults, and then there is a rise later in life after the age of 60. There are 4 subtypes of the classical Hodgkin lymphoma, and a fifth very, very rare subtype is called nodular lymphocyte predominant Hodgkin, and that resembles non-Hodgkin lymphoma in behavior. How is lymphoma presented? It is mostly presented with an enlarged lymph node, as you can see here. But also, patients can have big liver, big spleen. They can have what we call B symptoms, which are fevers, night sweats, weight loss. There could be rarely some extranodal, which is outside of the lymph node presentations, like a skin involvement, or bone, or lung, or bone marrow. Patients could have tiredness or itching as part of their presentation. And of course, abnormal full blood count, like increased lymphocyte count, or abnormal looking lymphocytes in the blood. Also, some patients might have low blood cell count due to bone marrow involvement. Pardon me. How do we investigate patients with lymphoma? We do blood tests, we do imaging, including a chest x-ray, CT scan, a PET scan nowadays is available as a modality of imaging for patients with lymphoma. Of course, a bone marrow biopsy, and I showed you where we take the bone marrow from, and also lumbar puncture to look at the cerebrospinal fluid and make sure that it's not involved by the lymphoma. These are the different imaging that we have to diagnose lymphoma, and this is an image of a PET scan, which is the new kid on the block. A PET scan is uses a glucose, highly active glucose, to detect the metabolic activity of the tumors, of the lymph nodes. Here you see some lymph nodes, and the uptake is high because they are highly active and highly dividing cells. It has good sensitivity and specificity, and it can be used at diagnosis as well as follow-up after treatment. But the most important, the one diagnosis that makes us say a patient has lymphoma or not, is a tissue diagnosis. Taking a small punch, a core biopsy we call it, from an affected lymph node. And this is how lymphoma is diagnosed. A normal lymph node looks nice, and this is the follicle, the germinal center that we looked at, and this is an abnormal follicular lymphoma slide with lots of little follicles. This is a clearly abnormal. So we can look under the microscope and say what type of lymphoma is what, and make a diagnosis. Of course, nowadays we have more tests as I explained to you earlier, looking at the cell markers of a lymphoid cell to make sure what type of lymphoma we're dealing with. And different subtypes of lymphomas have different cell marker presentations, and they have different gene mutations and gene abnormalities. As we said, T cells, NK cells, and B cells exhibit different cell markers. That is the basis of a cell marker study, or a flow cytometry, if you heard of it. What we do, we look at the different cell markers by shining a laser light after we attach a fluorescent dye to the different receptors or the different CDs that the different cells have. And then we look at the percentage of that fluorescent dye, and based on that percentage, if we see, for example, more CD19 and CD20, then the cell we're looking at is a B lymphoid cell. If we see that the fluorescent is a CD2 or CD3 or CD4, then that's a T lymphoid cells. And if it is CD16 or CD56, it's an NK cells, and so forth. Also, we've become really good and advanced at looking at the chromosomes and the gene themselves to determine the subtypes, the different subtypes of lymphomas. And for example, this is just an example. It's a bit complicated, but certain types, just to highlight to you, certain types of lymphomas have certain abnormal gene mutations. And we look at these by doing different genetic studies. We call it cytogenetics, to look here at the chromosomes and see whether there is abnormality within the chromosomes themselves. The one that we use commonly to diagnose lymphomas and different subtypes of lymphomas is called FISH study. It's efficient, it's fast, sensitive, it has good resolution. So these are the chromosomes within certain cells, and if there is a mutation within certain genes, we can count these mutations and determine them with accuracy and speed. We've gone a step further in the 21st century. We're now even looking at subdividing the lymphomas according to their molecular abnormalities into different subtypes. So diffuse large B-cell lymphoma is not a one disease. Not every diffuse large B-cell lymphoma patient has the same molecular genetics. There's two big subtypes of diffuse large B-cell lymphoma, the germinal center subtypes and the ABC subtype. We will go into the details of all these lymphomas in subsequent talks when we talk about aggressive lymphomas, follicular lymphomas, T-cell lymphomas, etc. in the next webinars over the coming few weeks. Why knowing the molecular genetics is important, why knowing a patient has a germinal center B-cell like or an activated B-cell like lymphoma is important, because the prognosis of the patients, the response to treatment and survival is different in these subtypes of lymphomas. So germinal center lymphoma do a bit better than post-germinal center lymphomas. And also it is important because we currently are developing treatments, specific targeted therapies we'll call them, to target different subtypes of lymphomas based on these molecular genetics, based on the translocations or the genetic mutations that different lymphoma cells have. And I will talk about the targeted therapies in a future webinar, I think in November, about all the new and exciting treatments and molecules that have been developed around the world and based on these different molecular abnormalities in the different lymphoma cells. So in summary, lymphoma is the most common form of blood cancer in the developed world. It accounts for around 5.3% of all cancer, and it involves the lymphatic system, and the two most common types of cells that are involved with lymphoma are B-cell lymphomas and T-cell lymphomas. 5% of all the cancers, of all the lymphoid cancers are non-Hodgkin lymphomas. Only 0.3% is T-cell lymphomas, and that include aggressive and indolent. Hodgkin lymphoma is less common. And the etiology, as I've shown you, is largely unknown. What causes the genetic mutations that leads to the development of lymphoma is largely unknown, but the abnormalities themselves are well characterized, as I've shown you, the gene translocations, etc. And with that, I end my talk, and I'm happy to answer questions.
Thank you so much, Samar. It's a fantastic talk, really, really, in depth and insightful. So thank you so much for sharing that with us. So we've got a few questions. I might read through those. We'll start off here. So the first one is from an anonymous attendee who has just asked, my haematologist mentioned that Roundup is probably responsible for a percentage of lymphoma cases. What are your thoughts?
That's a very good question. And as I've shown in the etiology slide, if you remember, that toxins, heavy metals, including Roundup or some of the agents, other agents in insecticides and pesticides have been implicated as a cause of some of the genetic mutations that can contribute to the development of lymphoma. But the development of lymphoma itself is complex. You need more than one hit. You need more than one genetic mutation for the lymphoma to evade our immune system, to evade the self-destruction and the apoptosis, and then for it to multiply. So maybe Roundup can contribute as one of the hits to the development of lymphoma, but I personally don't believe that it is the sole cause of lymphoma per se. So the patient might have had some genetic mutations through a previous viral illness or an immune problem, and then the Roundup was the second hit, and the lymphoma happened. But there is no published data that have, to my knowledge, that have shown that for sure Roundup does cause lymphoma on its own. So that is my take on it.
Awesome, thank you. We just have another question here. Is lymphoma more common in certain age groups or ethnic groups?
Yes, lymphoma is disease of the elderly. Non-Hodgkin lymphoma median age of diagnosis is 60. And the reason for that is with age, we acquire more genetic mutations. So if you have a one hit, if you have a cell that is dormant, that had evaded apoptosis or the self-destruction mutation, the older we are, the more likelihood that this cell will acquire more and more and more genetic mutations that will make it to proliferate, i.e. make it expand in size and form a tumor. So it is common in certain age group, which is the elderly. And that's, we see that in most cancers. It's a disease of older age. As far as looking at the young patients with Hodgkin lymphoma, we don't know why there is an increase in incidence of Hodgkin lymphoma in the teenage, early 20s age group, but we think it might be related to viral infections, including EBV infections like infectious mononucleosis.
Great, thank you. And that actually leads us into another question that's been raised here by Nicolette, who has asked, what is EBV?
It's Epstein-Barr virus. It is, it causes infectious mononucleosis. 90% plus of the population acquires this infection at an early age, in teen age. Our immune system are usually able to control the virus. You just get, it's called the glandular fever. You get a bit of a glands, you get a bit of fever, but our immune system controls it. But some of these EBV, which is the Epstein-Barr virus particles, stay dormant inside our lymphocytes, and for reasons we don't know yet, they might integrate themselves into the DNA of the lymphoid cells and alter the genetics of these lymphoid cells and make them transform into lymphomas, including Hodgkin lymphoma or Burkitt lymphomas, in which EBV is implicated as the cause of the genetic mutation and the transformation of the lymphoid cells to lymphoma.
Awesome, thank you for that. I've got another question here. This one is from an anonymous attendee. For a patient with indolent lymphoma, I heard that there can be a retreatment with rituximab if it comes back. How is it that the lymphoma cells are not resistant to that drug for future use?
That's another good question, because the person who asked it is right. When we treat lymphoma for the first time with an anti-CD20, which is rituximab, basically, the cells will lose the surface marker, which is the CD20, because we blocked it and we eliminated that type of cells that carries the CD20 by giving the rituximab. So sometimes when the lymphoma relapses and we do the cell marker studies, the CD20 is negative. And if that's the case, then there is no point of giving rituximab again, because the relapsed lymphoma cells do not exhibit that surface marker, so they won't respond to rituximab. But sometimes when the lymphoma relapses, the relapsed cells, when we do the cell marker studies, they carry the CD20. We can see the surface antigen CD20. And if that's the case, then retreatment with rituximab in combination with other chemotherapy agents is not unreasonable, because the cells will still respond because they have CD20.
Thank you. Got another question here. When an indolent lymphoma transforms to a higher grade lymphoma, how does that happen?
As I have shown, these types of lymphoma happen within the germinal center of the lymph nodes. So based on some genetic mutations, for example, follicular lymphoma have the 14-18 gene translocation, which is the BCL2, what we call, these cells behave in an indolent way. They multiply slowly. But sometimes with time, and I also explained that, these same cells continue to acquire more genetic mutations. They just change their genes in a way that make them more aggressive, that make them multiply faster, that make them change their shape from a round small cell into a bigger, large lymphoid cells. So it's all to do with the genetic mutations that these cells could acquire with time, and they change their behavior from a follicular lymphoma, slow growing cell, into a large cell lymphoma, a highly aggressive and rapidly dividing cell.
Great. Just a couple more questions, if that's all right, Samar. Thank you so much for your thorough answers. So Jeanette has asked, thank you for the information. I've heard that there is a possibility of a generalized theory of inflammation, and I noted that you put chronic inflammation as one of the possible causes for the development of cancer-causing mutations. Could you talk a little more about this developing theory?
It is well known that patients who have chronic inflammation, who have, for example, rheumatoid arthritis or systemic lupus erythematosus, where there is an increase in the level of inflammatory markers, including, for example, C-reactive protein, or their ESR is high, their immune system is active in this group of patients because there is a stimulus. Whether that stimulus is an auto antigen, as we explained, that the body itself is active and it's alert, and it's in a constant state of multiplying. The T cells are active and on alert. The B cells are multiplying, producing the antibodies, because there is the inflammation is there, whether it's a chronic inflammation because you have a sore joint, or it's a chronic inflammation because you have a chronic infection somewhere. All of these lead to activation of the immune system. And when the immune system is active, there is a higher chance of these cells that are continuously multiplying to deal with the infection, to deal with the inflammation, to deal with the source of a problem in the body, that something can go wrong and these cells could transform into lymphoma cells. I'm not saying that every patient who has inflammation has lymphoma, but quite a few of the patients that I see with low-grade lymphoma, for example, malt lymphoma or extranodal lymphomas, or gastric lymphomas, as I explained, with the H. pylori infection, that they have lymphomas. It doesn't happen in every patient, but there is an increased risk of this type of patients to develop lymphoma, just because our immune system is active. So there is an increased chance of something going wrong and lymphoma happening.
I think that touches on another question that we have here. Is it possible that my daughter had glandular fever, I picked it up, and then the result was Hodgkin's lymphoma at the age of 47? So maybe just
it can happen. It can happen. It's a bit older than the expected age of developing Hodgkin lymphomas at an earlier age, where infectious mononucleosis or EBV infection is implicated, but it can happen at any age. And most of the Hodgkin lymphoma cells are EBV driven, or the cause of the Hodgkin lymphoma is due to abnormalities in the cell cycle due to the EBV infection or particles integrated within the DNA. So it's a bit unusual, age 47, to have an acute glandular fever at that age, but it can happen at any age.
Great, thank you. That touches on just another point that was made. What would the lead-in time be for Hodgkin's lymphoma to develop to a stage 4 disease? But I think just asking about kind of expected timeframes of that, how long it might take.
I don't think there is a leading time per se. I actually think that I mean, if you have a small lymph node in the chest, and it's usually happen in the chest in the mediastinum Hodgkin lymphoma, and I mean, weeks, months, I don't know, but it also depends on the genetic mutations within the lymphoma cells, the Hodgkin lymphoma cells. Sometimes you have a small node and the node is there for a while, no problem. And sometimes you have a small tumor that multiplies and enlarges in size really fast, and then a patient to present within a few months or a few weeks with symptoms of shortness of breath or cough. So I don't like to think about it as that there is a certain time from when it's a stage 1, there is a small lymph node somewhere, to 3 weeks or 3 months or 3 years later, the patient is presenting with severe symptoms and advanced stage or stage 4. I think it's all to do with the behavior of specific patients, depending on the aggressiveness and the genetic mutations of these cells. But of course, the longer you leave the aggressive lymphomas, and including Hodgkin lymphoma, the more likelihood that it will spread and involve other organs, including the non-lymphoid organs like the lungs or the liver or other parts of the body.
Wonderful. Thank you so much, Samar, for all of your input and the detail that you've gone into to help us out. And I think we've all come away from today with a huge amount of knowledge. So we've got a couple of extra questions in here, but as we're just running over time slightly, I might just keep them for, on our YouTube page, our Facebook page, but also we have a few talks coming up. So those will be touched upon then. So yeah, I would like to wrap up things for our winter-spring webinar for today and just say a huge thank you to Samar for her informative and thorough talk on the biology of lymphoma. I'd also like to acknowledge World Lymphoma Day, which is coming up next week on the 15th of September. So please be sure to check out our website to register for the next 5 exciting talks on the subtypes of lymphoma. Also, if you would like to revisit this talk, it will be available on our YouTube page in the coming days. So once again, a very big thank you to you, Samar, And a big thank you to everyone who's tuned in for today's webinar, and we hope to see you at another one in the future. Thank you.
You're welcome, Natasha. Thank you.
Thanks. Bye.